Hello everyone, I am Dr. Suhas. Welcome you all to my YouTube channel. Today we are having Dr. Swathi with us, who has completed her BAMS from SDM College of Ayurveda, Udupi, and post graduation from the Department of Panchakarma, ITRA Jamnagar. Today she will be discussing about the topic of Parkinson's disease. Over to you, ma'am.
Thank you, Suhas. Today, we are going to see Parkinson's disease various aspects as well as role of Panchakarma in the Parkinson's disease. First of all, introducing the disease. Parkinson's disease, it comes under the category of extrapyramidal disorder. These extrapyramidal disorders relate to the dysfunction of the basal ganglia. They result in disturbance of movement and posture without significant paralysis. The term movement disorder is often used synonymously with extrapyramidal or basal ganglia diseases. Movement disorders can be broadly divided into akinetic rigid syndromes, nothing but Parkinsonism, in which there is paucity of movement called as akinesia or bradykinesia, often accompanied by an increase in muscle tone, that is rigidity, and hyperkinesia or dyskinesia, which are associated with excessive abnormal involuntary movements. Idiopathic Parkinson's disease is the most common akinetic rigid syndrome. Parkinson's disease is named after James Parkinson, who in 1817 wrote a classic called An Essay on the Shaking Palsy, a disease for which the reason is still unknown. Coming to the definition, Parkinson's disease is the most common form of a group of progressive neurodegenerative disorders characterized by the clinical features of Parkinsonism, including bradykinesia, rest tremor, muscular rigidity, shuffling gait, and flexed posture. Epidemiology. Parkinson's disease afflicts approximately 1 million individuals in the United States. Its peak age of onset is in the early 60s, that is, ranging between 35 to 85 years, and the course of illness ranges between 10 to 25 years. So, when we come to the etiology, actually, the cause of Parkinson's disease is still unknown. Environmental factors have been implicated. MPTP, a toxic product of heroin, was found to cause an acute clinical syndrome which was identical to Parkinson's disease, possibly even with the formation of Lewy bodies. Chronic exposure to MPTP-like toxin in the environment has been suggested, and here some causes are listed here. Risk factors include a positive family history, male gender, head injury, and exposure to the pesticides. In the picture, it's showing some gene mutation, exposure to certain toxins, low levels of dopamine, presence of abnormal proteins. So before going for the pathology, first we have to know some basic physiological concepts. In the basal ganglia, corpus striatum has a rich concentration of acetylcholine. So what is this acetylcholine? It is synthesized and released by small striatal neurons, upon which it has an excitatory effect. And one more, that is dopamine, which is synthesized by the pigmented neurons of substantia nigra and is transported via the nigrostriatal pathway to the corpus striatum, where it has an inhibitory effect on the striatal neurons. So coming to the functions, so this basal ganglia, it controls the movement. Dopamine, it is inhibitory neurotransmitter in the basal ganglia, and acetylcholine is excitatory neurotransmitter in the basal ganglia. Pathogenesis. Normally, functional equilibrium exists in the striatum between acetylcholine and dopamine. So what happens in the Parkinson's disease? There is a loss of pigmented neurons in the substantia nigra, in the midbrain, and locus coeruleus in the pons, with the characteristic intracytoplasmic Lewy bodies in the surviving neurons. As a result, the dopamine content is markedly decreased. There may be a decrease in other neurotransmitters like noradrenaline, 5-hydroxytryptamine, GABA, and substance P. So what happens in the Parkinson's disease? This is a course of the pathogenesis. Initially, there is a degeneration of the dopaminergic neurons that produce the dopamine. Later, loss of melanin-containing neurons produce characteristic changes in the depigmentation. followed by the formation of the Lewy bodies, and finally, loss of dopamine results in tremors, rigidity, and bradykinesia. So, clinical features, which can be broadly categorized into two categories. One is the motor feature, another is the non-motor features. Under the motor features, mainly we can see three cardinal signs. They are rest tremor, rigidity, and bradykinesia. Here, the tremor is particularly important as it is present in 85% of the patients with a true Parkinson's disease. A diagnosis of PD is particularly difficult when tremor is absent. A unilateral and gradual onset of symptoms further support the diagnosis. And some of the features like masked faces, which is nothing but expressionless face. When the patient comes to the clinic, we can observe the patient. In the happy mood or in the sorrow mood, the patient will be in the similar expression, that is nothing but expressionless face, followed by decreased eye blinking, stooped posture, decreased arm swing complete the early picture. So the tremor has a frequency of 4 to 6 Hz, which is present mainly at rest, called as resting tremor, typically appears unilaterally, first distally, and is suppressed on the voluntary movement. Another important sign is pill rolling type of tremor, that is, the distal muscles are affected more than the proximal, and the rhythmic tremor at the wrists and the fingers has been termed as pill rolling tremor. So, how the pill rolling movement is there, in the similar fashion, the patient will be doing continuously this pill rolling movement. It disappears during sleep and is aggravated by emotional excitement or the fatigue. This tremor may also be seen in the legs or the lower jaw. Rigidity. This is another important feature which is present over the entire range of movement, that is called as lead pipe rigidity. In some individuals, we can see cogwheel type of rigidity. That means the combination of tremor and the rigidity it gives rise to cogwheeling, which is best appreciated on passive slow rotatory movement of the wrist. Bradykinesia, the most disabling motor feature of the Parkinson disease. There is a generalized slowing of motor activity which interferes with all aspects of daily living, including rising from the chair, walking, turning in the bed, and dressing. Micrographia. When we ask the patient to write, the handwriting becomes smaller and eventually may become illegible. Festinating gait. The gait is slow and shuffling. With asymmetric involvement of lower limbs, there could be a noticeable limp. The associated arm swing is reduced. Patients may have a tendency to advance rapidly with the short steps, which is called as propulsion, as though they are chasing their center of gravity. Sometimes the feet may appear to be glued to the floor, and which is called as the freezing phenomenon. So it can be termed as propulsion and retropulsion. That means when the patient comes to the clinic, if you want to assess this, you can just pull the patient. The patient will be continuing in doing his steps. So in the other individuals, they will go to 2 to 3 steps and then they will stop. But in the Parkinson's patient, they could not do that. Next is the masked face, that is expressionless face. Then these are the motor features which we come to know, but the non-motor features which are vague, like the autonomic dysfunctions such as constipation, frequency of micturition and nocturia, excessive sweating and seborrhea, orthostatic hypotension. Sensory abnormalities also seen like anosmia. Then cognitive impairment, that is difficulty with the complete complex tasks, long-term planning and memorizing. Neuropsychiatric symptoms could be developed because of the daily activities are hampered, the patient may end up with the depression, anxiety, and the sleep disturbances, and the sexual abnormalities like libido. This is nothing but Parkinson's iceberg. What is this? The people which can see are the tremor, rigidity, echinacea or bradykinesia, and the postural disturbance. But the people could not notice the other symptoms like constipation, speech, etc., which is termed as Parkinson's iceberg, which we have to elicit properly for the proper diagnosis. On examination, globular tap is positive. Hypophonic voice, that is, the voice becomes soft, monotonous, and shuddering. The speech is more rapid than the normal. Regarding the spine, kyphosis, the head usually tilts forward and body becomes stooped. Finger nose test is positive, that is, overshooting when the object is reached, called as dysmetria. When we ask the patient to do this movement, finger nose test, that will be overshooting of his fingers from the nose. Then dysdiadochokinesia, that is nothing but rapid clapping. In this, the rapid alternating movements are not possible to perform, and another one is tandem walking, in which the patient cannot maintain his balance, that is poor balance. This is the staging Honanyar scale. It is from the stage 1 to the stage 5. How the Parkinson disease develops, it is mentioned here. Initially, it starts with the unilateral involvement. In the stage 2, it becomes bilateral. In the stage 3, with the postural instability, and stage 4, leading to bilateral involvement, and also the patient requires substantial help. And at the final stage, the disease will be fully developed, severe, and he will be restricted to the bed and the chair. So the progression and the mode of death. In most of the patients, the disease progresses gradually over about 10 years until they become wheelchair bound or bedridden because of severe bradykinesia, rigidity, and postural instability. So, how the death occurs here? Either it may be due to aspiration pneumonia, septicemia from the UTI, decubitus ulcers, or secondary causes like vascular disease or the neoplasia. In the investigation category, conventional laboratory studies do not help in the diagnosis actually. CT and MRI scans are normal or show only variable degrees of atrophy. So the best one is PET scans using the FDG. In the differential diagnosis, there are so many diseases which mimics the Parkinson's disease syndromes like multiple system atrophy, dementia with the Lewy bodies, progressive supranuclear palsy, normal pressure hydrocephalus, corticobasal degeneration, and the drug-induced Parkinsonism. These are the signs and symptoms and the history and the radiographic findings of the differential diagnosis. Finally, the diagnosis can be made. The accurate diagnosis is possible only with the continued observation of evolving clinical signs and symptoms. It is made on the basis of the history and clinical examination, handwriting samples, speech analysis, interview questions that focus on developing symptoms, and physical examination are used in the preclinical stage to detect early manifestation of the disease. A diagnosis of the Parkinson's disease can be made if at least 2 of 3 cardinal features are present. In the treatment, it falls under 3 categories: drug therapy, surgery, and rehabilitation in the contemporary science. Drug therapy, they are using the various drugs according to the stages. In the stage 1 and 2, they go for anticholinergics, amantadine, etc. And stage 3, 4, and 5, they go for the levodopa. In the surgery, they go for the deep brain stimulation, thalamotomy, pallidotomy, etc. procedures. Continuous enteral infusion of levodopa are currently employed. In the rehabilitation, mainly physiotherapy, the motor learning strategies, relaxation exercises, flexibility exercises, and the training to improve the strength and the balance. Now coming to the Ayurvedic view. Any particular disease in the contemporary science, we cannot correlate directly it into the one particular disease in the Ayurveda. So we have to analyze the dosha dushas initially and also the nidhanadi categories, that is samprapti ghatakas, and finally we can come to conclusion to a one particular disorder in the Ayurveda. So here I have collected some of the information in which the kampa or the vepatu word comes. First of all, under the 80 Vataja Nanatmaja Vikara in the Charaka Sutrasthana 20th chapter, the word Vepatu comes. In times of Acharya Charaka and Sushruta, cluster of symptoms like Kampa, Stambha, Cheshta Nasha, and Vak Vikriti were described in the different contexts, but they were not clubbed as a part of the disease. As a separate clinical entity, Acharya Madhavakara described Vepatu as Sarvanga Kampaha Shiraso Vayurvepati Samnata. Here the word Sarvanga Kampaha and also mentioned as Shiras. Then, especially Basavarajiyam, a text, for the first time gave an ambiguous description by explaining the clinical picture of Kampavata, which were similar to that of the Parkinson's disease. And Acharya Sushruta in the Nidanasthana mentioned Snayu Praptavata, in which the Kampa is found. Acharya Bhela has noted the symptom of Kampa in the condition of Asti Majjagata Vata. He says, Asti Majjagato Bhagnam Kampanam Gatra Shoshanam. And in the Ashtanga Sangraha, he mentions the Kampa under Sarvanga Vata, in which it suggests the involvement of Snayu as well as Vyana Vata. And we can see the word Kampa as a symptom in various disorders like Vataja Jwara, Ardita, Vataja Unmada, etc. Coming to the differential diagnosis, there are various Avarana conditions and Gatavata conditions in which we can see the symptoms of Kampa which are mimicking the Parkinson's disease like Kafavrata Vyana, Kafavrata Udana, Udanavrata Vyana. So most of the features of Kafavrata Vyana, that is Guruta Sarva Gatranam Sarva Sandhyastija Rujaha Vyane Kafavrate Lingam Gati Sangas Tatha Adhika. So usually the patients complaining of Guruta in the whole body and Gati Sanga and the Sarva Sandhyasti Ruja. So these are the symptoms which we have to analyze. Then Majjagata Vata and Majjavrata Vata. These are the two conditions which mimics the Kampa because why we can take the Majja Dushti here? One reference is there called as Kapalantara Majja Mastulunga. That means Mastulunga situated in the Shiras is also correlated to the Majja. So Mastulunga Dushti can be taken as Majja Dushti. When we come to the Samprapti, mainly we have to categorize the Samprapti under two headings. One is Avarana pathology, another is Dhatukshaya pathology. Because in the Vatavyadhi also, we come across these terminologies. And here, the Nidanas, like Sandarpaka Ahara Viharas, they contribute into the Swatantra Kapha Prakopa, leading to the Prakupita Kapha, causing the Avarana to the Vata, especially Vyana as well as Udana, and that will lead to the Paratantra Vata Prakopa and finally leading to the Kaphavrata Vata. And another set of Samprapti goes like Nidana of Apatarpaka Ahara Vihara and the age related factor, that is Jara and the Dhatukshaya, leading to the Swatantra Vata Prakopa, affecting the Mastulunga Majja in the Shiras and finally leading to the Majja Dushti or Majjagata Vata or Majjavrata Vata. Why we have to categorize this Samprapti into these two headings? This is very important because in Charaka Siddhisthana first chapter, we come across one reference. They are telling that Medah Kafabhyam Anilo Niruddha Shulanga Supti Shvayathun Karoti. That means the patient may come with a complaint of Shula, Supti, etc., which especially are focusing on the Vata Pradhana Vikaras. But here it is mentioned that one caution is told there may be a culprit, that is Meda as well as the Kapha, which may not be seen exactly in the patient, but we have to analyze it properly. If we don't do that, what happens? They are telling that Ativriddhi Anile na Adav Shastam Snehanam Brahmanam iti. Why it is told? So, in the condition of this particular Anila Vriddhi, if you go for Snehan and Brahmana, what happens? Sneham tu yunjan na buddhastu tasmai samvardhayatyevahi tan vikara. So, by thinking the Vata Vriddhi, if you go for Snehan or the Brahmana line of management, the patient may end up with the complication, the disease may aggravate because there is a main culprit, that is Meda as well as Kapha. So in such conditions, instead of jumping onto the Snehana initially, you have to go for the Rukshana. For this, there are two other supporting quotes mentioned in the Charaka Sutrasthana 13th chapter, that is, where we have to follow the Rukshana therapy. It is told that Samshodhana Dhrute Yesham Rukshanam Sampravakshate Na Tesham Snehanam Shastam Utsanna Kapamedasam. That is, here the highlighting point is Utsanna Kapamedasam. In the condition of Utsanna Kapha as well as Medavastha, if we want to plan the Samshodhana, initially you have to go for Rukshana before planning for the Sneha. And the same reference, even in the Ashtanga Hridaya also it is mentioned, that is, Abhishenna Ananaguda Marmastha Vyadhayeshtaye Urustambha Prabhratayo Rukshaniya Nidarshita. So these are some of the set of the conditions like Abhishana, Ananaguda, Marma Vyadhi, and one more is the Urustambha. In all these conditions, initially we have to go for the Rukshana line of management, followed by the Snehana. We can, if at all it is indicated, or if at all the patient ended with the Dhatukshaya condition. So how we can plan the treatment now? The treatment principles in the Ayurveda goes like initially for each and every disease they have mentioned the Nidana Parivarjana. Now here, though it is a Vata Vyadhi, initially we have to remove the Avarana followed by the Amahara as well as the correction of the Agni, and finally we can go for the Rasayana for replenishing the Dhatus. For the removal of the Avarana, what can we do? We can go for the different procedures. The Bahya Chikitsas like Dhanyamla Dhara or Takra Dhara or even the Kashaya Parishekas, that is Dashamula Kashaya with the Gomutra Dhara. Then Agni Chikitsa Lepa. This is one folklore practice which is well developed now in all the principles, in all the hospitals. Now this is practicing. This is in practice because this Agni Chikitsa Lepa, it is it is containing the drugs like Lashuna, Haridra, Sarshapa, Maricha, Lavanga. These are the dry drugs, and the wet drugs like Agnimantha, Nirgundi, Papata, Bandha, and Vanatulasi. All these drugs are having the Ushna Tichna properties which are very much helpful to remove the Avarana pathology. And even the Udvartana can be performed with the Trifala Churna or the Kolakulathadi Churna. This acts as Vata Kapahara as well as Avarana. These are the Bahya Chikitsas. Even we can go with the Abhyantara Chikitsa, that is to remove the Kapha or the Pitta Avarana. So we can go plan Tikshna Nasya or the Vairechanika Nasyas. These Vairechanika Nasya also help to remove the Sroto Avarodha, and even we can plan the Virechana line of management also. If the patient is having the Pravarabala, we can go for classical Virechana. If that is not possible, even Sadhyo Virechana or Nitya Virechana is also sufficient with the Gandharva Hasta, the Eranda Kaila. According to the Koshta, you have to decide the dosage as well as the duration. Then, after assessing the Ama Lakshana, in case of association of Ama, you have to go for Apatarpana line of management, that is Langhana or Langhana Pachana or the Doshavasechana, according to the Mrudu, Madhyama, and Pravarabala of the Dosha as well as the Atura, which acts as Amahara as well as Agnivardhaka. After doing all these things, we can go for the Rasayana line of management, that is to replenish the Dhatu, or even if the condition already came with the Dhatu Kshaya, we can directly plan the Rasayana line of management. Initially, we can go for the Abhyanga with the different Tailas. If at all you need the Avaranahara line of management, you can go with the Brihat Saindhavadi Taila, or else for the Brahmana effect, you can go for Mashatma Guptari Taila or Mahamasha Taila. In case of Basti, initially you can plan Shodhana Basti, followed by the Rajayapana or the Madhutailika Basti. In the Shodhana Basti, any Tikshna Bastis, either it may be Kshara Basti or Mehabhishandahara Basti, you can plan. Then Matra Basti can also be planned later, but in the Matra Basti, if you ask the patient to do in the home, you have to ask him to come for the follow-up in between. Otherwise, if at all, again the Avarana pathology interferes there because of the Nidana consumption by the patient, again it may end up with the complication. Then Shashtika Shali Pindasveda, Abhyanga, Vizichil, Shirobasti, all these things are helpful for the Brahmana, but the caution should be there. We have to think regarding the Avarana in between, because if the patient is in the home, they may go for the Nidana consumption. Thank you.
Thank you, ma'am. Thank you very much for your very informative session.